Welcome to this lecture on ethics in clinical practice. What I aim to do in this lecture is firstly to consider an approach to considering ethical questions in clinical practice, and then explore the key elements of ethics as related directly to clinical care, beneficence and non-maleficence, patient autonomy, and quality of life issues. The bioethicist Albert Johnson proposed a four-stage approach to deliberating about ethical problems in clinical practice. Just as every clinical case presents an extensive array of facts and details that the clinician must interpret in order to arrive at a diagnosis and determine an appropriate treatment plan, so too clinical ethics problems must have some method to collect and organize the facts and opinions raised by the ethical dimensions of a case. The four topics approach suggests that we first consider the medical indications for treatment, which speaks to the ethical concepts of beneficence and non-maleficence. Then consider patient preferences, which is related to our respect for patient autonomy. Move on then to think about quality of life issues, which encompasses beneficence, non-maleficence, and respect for autonomy. And then finally consider any contextual features which might assist in resolving the ethical problem or dilemma. The contents of the four topics, viewed together, form a comprehensive picture of the ethical dimensions of a case. Once the facts and other information have been organised, they can be weighed in order to, so far as is possible in each individual case, find the right, or more usually, the more right or more reasonable solution. So, although beneficence, the primary ethical principle of medical indications, might be the most weighty consideration in most cases, it carries far less weight when no treatment can effect a cure. More precisely, its weight is converted from the obligation to cure to a duty to provide comfort and to enhance quality of life. Beneficence and non-maleficence might be summed up by this sentence by Hippocrates from his collection of case histories known as Of the Epidemics, written around 400 BCE. As Johnson suggests, a statement of the medical indications for treatment should be the starting point for an ethical discussion. Beneficence, then, relates to our efforts to relieve the patient of the burden of disease and its attendant pain, distress, and loss of function, while non-maleficence means going about these activities in a way which prevents further injury and reduces risk to the patient. Ethical dilemmas arise when these ethical principles conflict, or when medical intentions do not align with the desires or preferences of the patient. Canadian physician William Osler was one of the founding professors of the Johns Hopkins Hospital, is famously quoted as having said that medicine is a science of uncertainty and an art of probability. Probability is central to any risk-benefit discussion about medical treatment. Determining the benefits versus the potential risks associated with a medical intervention or treatment appears straightforward enough, but is actually a very complex exercise. Usually, the risks of a medicine or intervention are of a totally different nature and frequency compared to its benefits, a bit like comparing apples to oranges based on their weight without considering other important parameters such as taste and texture. For most medicines, for example, the benefits are often limited to a few indications, and for an individual patient, there is usually only a single benefit sought, but the potential risks are multiple. Disparate information is difficult to compare without introducing serious errors. Conversely, if large amounts of information are to be considered, contrasted, and compared, this can lead to a level of complexity that stifles decision-making both for the clinician and for the patient. Perceptions of risks versus benefits are also notoriously susceptible to the context in which they occur. Sometimes the risks of a medicine or intervention are given greater emphasis by the clinician relative to the risks of the disease, because whilst the clinician is not responsible for the presence of the disease or the symptoms it causes, they feel causally responsible for the risks associated with the treatment. In addition, patients often have the misconception that medicines and medical interventions should be completely safe, and I see this fairly often in my own practice in clinical negligence. This may lead them to dwell excessively on any risks to which their attention is drawn. If, however, their clinical situation is dire, they may be willing to accept hazardous and upsetting treatments with little question. Perceptions of risk may therefore be different from the actual risk. In the end, in any given situation, the acceptable risk to benefit balance is an individual judgment made by the patient after consultation or by the prescriber on behalf of a patient. The competence of the clinician to use his or her knowledge and skills to benefit the patient and the expectation of the patient to benefit from that competence are key components of the therapeutic relationship. Beneficence and non-maleficence are central to this relationship. The therapeutic relationship lies at the heart of the modern concept of medical professionalism, which requires that clinicians and other healthcare professionals maintain honesty and integrity, respect for patients, commitment to patients' welfare, compassionate regard for patients, and a dedication to maintaining their competency in knowledge and technical skills. Overall, clinicians must act in a way which avoids the exploitation of patients for their own profit or reputation. Thus, professionalism and ethics are linked such that the ethical obligations and professional responsibilities of clinicians are closely aligned to their ability to fulfill the goals of medicine in conjunction with their respect for patients' preferences about the goals of their own lives. In their book Clinical Ethics, A Practical Approach to Ethical Decisions in Clinical Medicine, Johnson, Ziegler and Winslade propose addressing the issue of medical intentions by answering these 5 questions. For the most part, arriving at a list of differential diagnoses and treatment options will implicitly answer all of these questions, but it's important to consider them explicitly when trying to address an ethical question. Number 1. What is the patient's medical problem? Is the problem acute or chronic? Is it critical or emergent? Is it reversible? The answer to this question will usually be derived from standard methods of clinical medicine: history, examination, laboratory data, and other investigations, leading to a list of differential diagnoses and a plan for further tests and treatment. We need to be clear about whether the ethical problem relates to an acute reversible condition, such as an infection, in a previously healthy individual, or in a patient who has a late-stage terminal illness, or perhaps to an acute episode in a patient with a chronic condition, such as ketoacidosis in someone with diabetes. All parties involved need to be clear about both the disease and the proposed treatment. The disease may be acute, rapid onset and short course, or chronic, persistent and progressive. It could be an emergency, causing immediate threat to life or disability if not treated, or non-emergency, stable or slowly progressing, or even self-limiting. Finally, are we dealing with something that is curable, causes known and treatable with definitive therapy, or incurable? A large number of problems arise when patients or family members do not understand, often because no one has taken the trouble to explain to them, what these terms mean and the nature of the illness. Second, what are the goals of treatment? Goals of treatment might include any or all of cure of the disease, maintenance or improvement in quality of life by relieving symptoms, promoting health and preventing disease, preventing untimely or premature death, improvement of functional status, or at least the maintenance of an existing compromised level of function, education and counselling about the patient's condition and their prognosis, providing relief and support near to the time of death. In many cases, most of these goals are achieved simultaneously. For example, if you have a patient with a urinary tract infection who has symptoms of urinary urgency and incontinence, curing the infection will also relieve the symptoms and improve their immediate functional status. Sometimes, though, these goals will conflict. An example might be when we start antihypertensive medication in an asymptomatic patient with the goal of reducing their risk of stroke or heart failure, but increasing their risk of side effects such as dizziness and erectile dysfunction, thus reducing their quality of life. Ethical problems can occur when the goals of treatment are poorly defined or when they need to be revised as the patient's condition changes. Goals that are perfectly reasonable when a patient is admitted for a semi-elective surgical procedure may no longer be reasonable if the patient has a perioperative cardiac arrest and now has a suspected anoxic brain injury. I'm reminded here of a case that I dealt with when working as clinician in charge of the resuscitation room. A 60-year-old lady was brought in by ambulance who had suffered an out-of-hospital cardiac arrest. Paramedics had managed to get return of spontaneous circulation and transported her to the emergency department. The resuscitation team is usually led by the ED clinician in the resuscitation room, so this particular day it was me. And I was joined by colleagues from acute medicine and anaesthetics. And together we intubated and started the patient on ventilation, did some bedside testing, etc., and determined that the most likely cause of her cardiac arrest was a thrombus, either cardiac or pulmonary. And she was in a very brittle state and not especially likely to survive, but nonetheless, to determine the cause of her state, we decided that we needed to get some CT scans of the brain, but also of chest, abdomen, and pelvis to look for pulmonary thrombus. So whilst my colleagues were preparing the patient to go to the CT scanner, I went out to the relatives room to brief the fairly large group of family members that were gathering there. So I explained the situation. I explained that I thought that their mum and sister, auntie, etc., was gravely ill, but and not breathing on her own at the moment, but she did have a pulse, and we were planning to take her for CT scans. I answered any immediate questions that they might have, and then I returned to the resuscitation room, where my colleagues informed me that while I was out, the lady had suffered another cardiac arrest. And between us, we determined that actually, with the patient's physiological state and the blood gas results, etc., she had suffered a non-survivable event. And CT scans were not going to alter any course of treatment and would not be appropriate. So I then had to go back out to the relatives room and update the family members. And as you can probably imagine, this created, having been there just 5 minutes earlier, telling them that we were taking their relative for scans, this created quite a lot of anxiety, some questions, but also quite a bit of resentment. Now, all of this was resolved when I took them two and three at a time into the resuscitation room to be with their relative while she took her last breaths, and they could clearly see at that point that she was in fact actively dying, and several of them were present when when heart stopped beating and we withdrew monitoring. So that case just goes to illustrate how changes in circumstances can lead to the need to potentially ethical problems and the need for very careful conversation with family members. Question number 3, in what circumstances are medical treatments not indicated? This is the area that probably causes the greatest number of ethical problems in clinical medicine. The determination of whether a particular intervention is or is not indicated and explaining this determination to patients and family members in a way that ensures that they both understand and agree is a significant challenge. Generally, an intervention is indicated when the patient's impaired physical or mental condition is likely to be improved by the application of that intervention. Interventions may be non-indicated for a variety of reasons. First, the intervention may have no scientifically demonstrated effect on the disease and yet be erroneously selected by the clinician or desired by the patient. One example might be the use of high-dose chemotherapy followed by bone marrow transplantation for widely metastatic breast cancer, or the use of estrogen replacement therapy in a postmenopausal woman in the mistaken belief that it will reduce the risk of coronary artery disease. These treatments are non-indicated. Second, an intervention known to be effective in general may not have the usual effect in some patients because of individual differences in their physiology or in the disease process. One example of this type of intervention would be a patient who takes a statin and subsequently experiences an acute myopathy. Statins would therefore be non-indicated for that patient. Finally, an intervention appropriate at one time in the patient's course may cease to be appropriate at a later time. An example might be that of ventilatory support, indicated when a patient is admitted having been resuscitated following out-of-hospital cardiac arrest, but no longer indicated when the patient is determined to have profound anoxic brain injury or multi-organ failure. Cases in which the usual goals of restoration of health and function seem unobtainable present themselves when we have a patient who is actively dying, a patient with a terminal illness, or a patient with a progressive and inevitably lethal disease. 4. What are the probabilities of success of the various treatment options? Judgments about diagnosis and treatment will always reflect a level of certainty or uncertainty. Given the nature of medical science and the specific circumstances of each patient, clinical judgment is never absolutely certain. The central task of the clinician is to reduce uncertainty as far as possible by using the available clinical data, medical science, and reasoning to reach a diagnosis and propose a treatment plan. This process is referred to as clinical judgment or clinical reasoning. Much of the uncertainty of clinical reasoning can be reduced by the methods of evidence-based medicine, using data from clinical controlled trials where available, and by the development of clinical practice guidelines, which assist a clinician's reasoning. Although evidence-based medicine and practice guidelines aim to reduce uncertainty, some degree of uncertainty will always remain, because these methods can only reach general statistical conclusions that may or may not fit the individual patient. I frequently find myself reminding clinical colleagues, especially paramedics, that blindly following a guideline in all circumstances is as bad as not knowing that it exists. In addition to the uncertainty about data and its interpretation, there will be uncertainty about what action to take in any particular case. Clinicians are frequently confronted by situations in which we have medical evidence about what we can do, but this doesn't tell us what we should do. Given all of the possibilities, what goals are appropriate for this particular patient? These questions cannot be answered solely by clinical data. The ethical principles of beneficence and non-maleficence reduce the scope of this sort of uncertainty by directing intention and effort away from the wide range of possible diagnoses and treatments towards the more narrow range most likely to apply to this patient in these circumstances. However, the ethical principles do not dictate particular clinical decisions, and clinicians who have made best effort to reduce uncertainty by using medical data and ethical principles may still be uncomfortable about moving from intense therapy to more passive approaches when it becomes apparent that treatment can do no more. There's no simple answer to this dilemma. It must be confronted in candid, realistic discussions between clinicians, the patient, and, if appropriate, family members. This is the shared decision making that constitutes an appropriate professional relationship. The final of the 5 questions then involves summing up how the patient can be benefited by the medical interventions and how harm can be reduced or avoided. So in summing up the likely or possible benefits to the patient, we move beyond the gathering and sorting of factual information and try to assess how these facts relate to the principles of beneficence and non-maleficence, and then how that can translate into a recommendation about appropriate action. When the clinical facts reveal a condition that is probably treatable, and when the risk-benefit reasoning inclines towards intervention, the principles of beneficence and non-maleficence urge a prudent medical intervention. When, however, the facts favour the opinion that the condition is not amenable to treatment, or when the harm that might occur as a consequence of treatment is significant, the obligation to intervene is diminished or even extinguished. The principle of non-maleficence then becomes stronger, directing the alleviation of burdens on the patient. Even then, certain benefits of nursing care and palliative treatment may remain possible. The clinician's judgments about these objective benefits must now be fashioned into a recommendation to the patient based upon our knowledge of the goals and values of that patient. The patient may then accept or reject that recommendation based on their own personal preferences. Before we move on to discuss patient preferences, I want to focus on some of the things about non-beneficial treatments, and in particular ethical considerations associated with resuscitation and do not attempt resuscitation processes. This is closely related to our previous discussion of probabilities. The question is, what justifies withholding or withdrawing a particular treatment when there is a high probability that it will be unsuccessful? This is often referred to as medical futility, although more recent literature favours the terms medically ineffective or non-beneficial treatment. It refers to a situation where an effort to provide a benefit to the patient, which reason and experience suggest is highly likely to fail, and whose rare exceptions cannot be systematically produced. Rather than being an absolute concept in which treatment is guaranteed to fail, it is more often a judgment about probabilities, and the accuracy of that judgment depends on empirical data from clinical studies and from clinical experience. 3 main questions arise in this debate. What level of statistical or experiential evidence is required to support a judgment that a treatment will be of no benefit? Who decides whether an intervention is non-beneficial, clinicians or patients? What processes should be used to resolve disagreements between patients or their surrogates and the medical team about whether a particular treatment is non-beneficial? The use of statistical probability is challenging for clinicians and patients. We are frequently presented with drug trials that have been powered in such a way, e.g. by methodology or participant numbers, such that results appear statistically appealing. One of the skills of the clinician is to translate this statistical probability into clinical utility by understanding concepts such as intention to treat, numbers needed to treat and numbers needed to harm, ecological validity, etc. And, more importantly, to translate this for patients. I have occasionally in my legal practice had to explain some of these concepts to potential claimants. One example was the case of a gentleman in his 70s who died following an emergency cardiac surgery where the patient and family were told that around 5% of people do not survive the procedure. Now, they interpreted that as meaning that that individual patient, had a 95% chance of surviving that procedure. Of course, these statistics are population level statistics, and I took some time to point out two things to them. Firstly, a 5% death rate in the population of people that undergo that procedure is actually a high rate of mortality. And two, if you happen to be in that 5% segment of the population who undergo that procedure, then your chance of dying is 100%. This is the problem with statistical probability, and more specifically, throwing out such probabilities to patients without explaining what they really mean for that individual patient's treatment. Inevitable debates ensue about the level of probability that should represent the non-beneficial nature of treatments. Who has the authority to establish the goals of the intervention and to decide the level of probability for attaining such goals? Some ethicists argue that clinicians have the right to refuse to provide treatments that they believe highly unlikely to produce beneficial results. Others maintain that non-beneficial treatments must be defined in light of subjective views, values, and goals of patients, or sometimes their surrogates. This has implications not just in terms of beneficence and non-maleficence, but also in distributive justice. Is it really right that a patient receives a treatment that is unlikely to be beneficial at the inevitable expense of someone else receiving that or some other treatment, or at the burden of the healthcare system? This is why such decisions are not just individual, but societal, and why clinical and cost effectiveness guidelines are important. Now, clinicians, not surprisingly, find it extremely difficult to apply the concept of non-beneficial treatment in practice. Its probabilistic nature always leaves room for some unexpected turn in a patient's situation, and it has the undertone of giving up. Still, it highlights the necessity to make decisions about treatments that are of questionable benefit and to introduce a note of realism into excessive medical optimism by inviting clinicians and families to focus on what realistically can be done for the patient under the circumstances and which goals, if any, can be realised. This requires the opportunity to open an honest discussion with patients and their families about appropriate care, and it calls for a careful investigation of the literature about the efficacy of proposed treatments in particular situations. Clinicians should never invoke futility except in the sense of medical ineffectiveness in order to avoid a difficult conversation with the patient or family, or when the real problem is actually a frustration with a difficult case or a reflection of the clinician's own negative evaluation of the patient's future quality of life. A judgment that further curative treatments would not be beneficial is not the same as a judgment that treatment should cease. Rather, it signals that discussions of the situation with patient and family are mandatory. And there are cases where these discussions and decisions can lead to legal challenges. Just to highlight that, a couple of fairly recent cases from the UK. The picture at the top of the screen there is a little boy called Alfie Evans. Alfie was born in May 2016. He was admitted to the Alderhay Children's Hospital in Liverpool in England in December 2016 after suffering seizures. He was diagnosed with a degenerative neurological condition, but clinicians were not able immediately to identify definitively what that was. Alfie remained in hospital for more than a year. He was intubated and ventilated and in a vegetative state for the majority of that time. Scans revealed catastrophic, non-survivable degradation of his brain tissue, but Alfie's parents disagreed with the medical team. The situation was further complicated in this case by the involvement of an evangelical Christian organisation who argued for the sanctity of life at all costs, and the parents then wanted to fly Alfie to a hospital in Italy. This is a hospital that had links to the Vatican, and they suggested that they would perform procedures which might help him breathe and would keep him alive for an undefined period. The hospital sought legal injunctions against this, arguing that further treatment was not only futile but also unkind and inhumane. And after multiple hearings and appeals, the courts endorsed an end-of-life care plan for Alfie, stating that they were making the decision in Alfie's best interests. And he subsequently died, I think, in about April or May 2018. The bottom picture there was another more recent case. This was a young man called Archie Battersby. Was a 12-year-old boy who was found unconscious at his home in April 2022. He'd sustained severe brain injuries, and the initial thought was that he had been trying some online challenge at home, some misadventure. His brain damage was recorded as unsurvivable catastrophic hypoxic ischemic injury. His parents disagreed with the assessment of the medical team, and with the support of that same Christian organisation, they took their claims through the court system, eventually losing an appeal at the Supreme Court. Archie eventually died in August 2022, and the coroner concluded that his death was an accident resulting from a prank or experiment gone wrong. Both of these cases drew a great deal of media attention, and in addition to the prolonged distress caused to the parents of both of the children during the protracted legal battles, both cases took an enormous toll on the healthcare teams involved, and staff were subjected to abuse and threats by so-called supporters of the families.